Welcome back, listeners. You're listening to EBC Radio. This is 1170 AM. It's time once again for Heartbeat. I'm Dr. Dinesh Singhal. I'm an interventional cardiologist. I'm the director of the catheterization laboratory at St. Peter's University Hospital and an attending cardiologist at Robert Wood and Princeton. This program airs every second and fourth Saturday on EBC Radio on 1170 AM. You can also listen to it live on www.ebcmusic.com. And if you have an interest in any of our older shows, go to heartbeatradioshow.com and you can listen to our previous programs. And we also have a Facebook page on Heartbeat Radio Show. A few days ago, there was an important news story. Some of you may have noticed it. It was related to some news in the breast cancer world. And the New York Times headline said, "Good news for women with breast cancer. Many don't need chemo." This year about over 250,000 new cases of breast cancer will be diagnosed in just the U.S. alone. And about close to 50,000 of them will actually wind up, unfortunately, dying. So it is an issue which is kind of in the forefront in women's health. And even though we've kind of touched on it in the past, it never is always enough. And we have in the studio with us Dr. Seeta Trivedi. She's a medical oncologist with the Regional Cancer Care Associates. And there couldn't be a better person than an oncologist to help us understand, what this new research suggests, because it sounds like that some women within this realm of breast cancer will be able to avoid chemotherapy. We just won't talk only about that. We will dwell on it, but we'll put it in the context of just the overall management of breast cancer. As always, the phone number in the studio is 732-297-9886, 732-297-9886. If at any point you want to join in the discussion, have a question, a comment, or some clarification. So I thank you again for tuning in, and hopefully you encourage your friends and family to listen. But with that, Dr. Trivedi, thanks so much for joining us.
Hello. Yes. Hi, Dr. Singhal. Thank you so much for this opportunity, and I'm very happy to be able to be on the show. I enjoy listening to the show, and it's always been informative for our listeners. So I'm here to be able to help with whatever questions or comments people may have, and share some of the knowledge about what's been in the news recently.
Great. So just to set the stage, let's just talk a few general things about breast cancer.
Right.
What age group generally this problem afflicts women?
So, unfortunately, just like all other cancers in the U.S., we are seeing women being diagnosed at a younger age. However, breast cancer is usually a cancer that happens past the age of 40s. According to most clinical guidelines and U.S. Preventative Task Force guidelines, mammography screening for breast cancer should start at around the age of 40. And thereafter, it should be every year. Some guidelines suggest until the age of 50, women can screen every other year, but the guidelines are strongly suggestive of yearly mammography screening once you hit the age of 40.
Now, some, the women who've been through a mammogram know what it is.
Right.
But there may be people listening who may not know what it is. So what is a mammogram?
Correct. So a mammogram is a radiological assessment of the breast tissue, the skin of the breast, the lymph nodes to a certain degree in the armpit or the axilla, in order to try to see if a benign, which is a non-cancerous, or a cancerous tumor or lump is visible in the breast, which could be harmful to your health. People tend to think that they can feel breast lumps if they get breast cancer. This is not true in the majority of cases, specifically if you're aiming to find a lump at an early stage, which is very important because the earlier the cancer is found or the lump is found, the greater chances are that the treatment is going to be a lot easier and a lot simpler, and it is going to not harm your health in a bad way.
So how reliable is a mammogram? If a mammogram comes back abnormal, are there some characteristics in which the radiologist is very comfortable? So if you had 100 mammograms, is there a ballpark percentage of what will turn out to be cancer and what not?
Right. So there are screening guidelines, and this is called the BIRADS, BIRADS, BIRADS system of assessing what we see in the breasts. Now, it is always important to make sure that when you are doing your mammography screening, you are doing it at a center that has breast mammography radiologists, St. Peter's, JFK Hospital, Robert Wood Johnson. These are all big institutions that have dedicated breast radiologists who are good at reading mammograms. But your mammogram report will come with certain wordings on it that oftentimes confuse women. So let me just explain how it is written. The first part of the report usually tells you whether there is anything or not. The second part of it is often a disclaimer, which says that if you have dense breasts, then there is a 10% chance that we might miss a lump. And this information is often misleading and confusing. What it means to say is that every woman have different breasts. And depending upon how much fatty tissue or fat you have in your breasts, depending upon your age, depending upon your time in your menstrual cycle, if you're still premenopausal, depending upon how many children you may have had, and depending upon how old you are, your breasts might be very dense, meaning have a lot of milk ducts, a lot of fat tissue, and a lot of glands, and so might make it a little harder to see a small tumor lump, or you might have breasts that are very clearly visible on the films, and you can tell with a great degree of certainty that you don't have anything to worry about. If your mammogram readings come back as something above BIRADS 3 or BIRADS 4, the radiologist will usually recommend for you to talk to your doctor and to figure out if you need another test to look at it more closely. This can be an ultrasound of the breast, which uses sound waves, ultrasonography, or it could be something called an MRI of your breasts, which help to pick up more details of the lump, more details of your armpit to see if there's any lymph nodes that might be involved, so on and so forth.
So I think if I were to worded in this way, that not every abnormality implies that it's going to turn out to be something
Correct.
serious. So one should not panic. On the flip side,
Correct.
One should not ignore it either and do whatever is recommended, because if the breast cancer can be diagnosed at an early stage, it potentially could have a much better prognosis than if it's not.
Correct.
So
a normal mammogram is usually a BIRADS 1 or a BIRADS 2. So if you see those numbers on your report, then that means that you've had a normal reading. If it says a BIRADS 0, which it might, that basically means that the radiologist might want you to come back to get some better pictures, or a different time of the month if you are premenopausal and in your cycle. If you get a BIRADS 3 on your report, that means that you might have to come back in shorter time than an year to repeat your study, which is usually 6 months. A BIRADS 4 suggests that you need to talk to your doctor right away and that you might have a cancerous lump. So if there is anything that says BIRADS 4, it will say suspicious. The radiologist will take the time to come out and tell you about it. And in this situation, you should contact your doctor.
So just to clarify, the word BIRADS, is not it's not a computer generated number. It's the characteristics of the findings, and you kind of he adds up a few scores based on what he's seeing to come up with a number, right?
Correct.
So you're listening to Heartbeat. This is EBC Radio. I'm Dr. Dinesh Singhal. We're speaking to Dr. Seeta Trivedi. She is an oncologist with the Regional Cancer Care Associates. And our topic today is about breast cancer. The phone number in the studio is 732-297-9886. Now, I know we talked about mammography. However, along over the years, people have been advised to also do some self-exams because, maybe somebody misses to get their mammography. Or there may be a problem at an earlier age than 40.
Correct.
So, tell us a little bit about the appropriate practice of when to start self-exam, how often to do it. But before we do that, let's take this caller. Hi, you're on the air on Heartbeat.
Hi. I have a question for a cardiology doctor.
Sure.
I am taking Brilinta because I have a few stents. And how long I had to take a Brilinta?
Okay, so
I've been taking for 2 years now.
So Brilinta is given when stents are put in. I'm going to give you a general answer because it kind of will vary from person to person, and your cardiologist is your best person who is going to make that call. So we typically, in most cases, give it for about a year along with aspirin, but there are instances where it may make sense to continue it for a longer period. So this is a very patient-specific answer, but in large part, for most stents, we use it for a year. Now, the reason we give it is because when the blood comes in contact with the metal of the stent, it tends to clot. Now, within a year's time, tissue from within the artery kind of covers the stent, so the stent's no longer visible to the bloodstream and it doesn't clot. And so that's typically the period, but sometimes depending on the number of stents, where it's located, if there was a heart attack involved, sometimes we continue it for a longer period. So, this is where you're going to have to turn to your cardiologist and ask him that question. It's an appropriate question now that you're 2 years out. Okay?
Okay, thank you so much.
Okay. So, it was a little deviation from our topic, but, that's okay. It's an open forum. So, going back to self-exam,
yes.
What would you recommend as to how it should be done?
Sure. So, again, prevention is always better than cure. It is important for most women to remember that, the incidence of cancers are rising. And so if there is something that you can do about it, you should know about it. A lot of primary care doctors' offices will offer shower cards. There's a lot of material out there on the internet. There's a lot of breast cancer based groups that are trying to promote. But you should start self-breast exams probably past the age of 35. This is not hard and fast. However, there's two separate risk categories that we talk about. One of the category is if you have someone in your family who has had breast cancer, if you have more than 2 first-degree relatives who have had breast cancer, that is your mom and your mom's sister, or your mom's mom, your dad's side of the family, his mom, and then his sister also, or if you have any first cousins. So if you're seeing 2 people in the family who already have had breast cancer, and you do not know if they do carry a genetic mutation that increases your risk, then this is something that you definitely want to be very careful about. There are only actually 10 to 15% of all the breast cancers that are genetically driven and that are hereditary, meaning that they are passed down. Misconception sometimes is that, if somebody had cancer in the family, that means that I'm going to get it. That is not correct. 85% of all breast cancers still are what we call sporadic, or just happen by chance, not because of something that is genetically passed down. But nevertheless, you should start getting familiar with your body. by the age of 35 to 40, you should do a breast exam once a month on a minimum. And the best time to do it is towards the end of your menstrual period, when your breast tissue is technically softer and you are more likely to pick up anything that you may not. Breast exams typically should start from the top of your armpit. You can use your finger pads or your fingertips to use a circular rotating motion going down towards your breast, again starting from the outside and moving in, spiral-like circular motions towards the inside. Any bleeding from the nipple, any abnormal milk discharge or any other mucus discharge from your nipple, any hard lumps, any changes in the skin, any skin rash over the breast that is not going away are signs that you should show your doctor right away. The chances are that you probably still might pick up a lump that would not have been picked up by mammography if your mammography was 6 months or so ago. Certain populations of patients who are at higher risk of getting breast cancer can develop slightly more aggressive cancers. Younger women can develop more aggressive cancers, and these sometimes grow very quickly. And your self-breast exam might actually be the key to saving your own life. So it is very important to do that.
Now, you dwelled on the role of genetics in the occurrence of cancer. Are there any other risk factors which predispose women to a higher incidence of breast cancer?
Right. So there are certain very specific factors that we have identified in the breast cancer scenario. There are two specific genes, BRCA1 and BRCA2, that if caught, they increase your risk of having both breast cancer and ovarian cancer. Certain general risk factors for breast cancer do include obesity, patients who have not had children, so nulliparous patients, women who start getting their periods at an early age, women who do unfortunately use birth control pills for many years, women who have not breastfed. These women do fall into a slightly higher risk. There are certain calculatory models that we use called the Gale model to calculate based on age, based on these other risk factors, like a number of children, the age at the first pregnancy, whether you breastfed or not, whether you used any hormone contraceptives or not, to see what your lifetime risk is. Alcohol, for example, cardioprotective, but does increase the risk of breast cancer, unfortunately. So, yes, these are things that you have to be careful about.
So if a patient calls you or is referred to you who either picks up a lump on a self-exam or goes through a mammography and is found to have some kind of a problem, what's kind of the next step at that point of time?
So the next step at that kind of time, if your primary care physician has referred you for a mammography, and it's important to note that you can actually walk into a imaging center and ask for a mammography.
So you don't need a prescription
without a prescription. You do not for a screening mammogram. Now, if you tell them that you need to get a mammogram, they will, and you tell them that you have also found a lump, they might try to make things a little easier for you by calling your doctor and suggesting that you get a slightly more detailed mammogram called a diagnostic mammogram rather than just a screening mammogram.
So what's the difference between a screening and a diagnostic?
A diagnostic mammogram uses a little bit more detail in terms of the number of views or the number of films or pictures that are taken in a diagnostic mammogram are a couple more than what you do in a regular screening mammogram. Also, talking about resolution, for example, if you look at a picture taken by a iPhone camera versus, a long lens camera, there's a difference in clarity. So diagnostic mammogram uses a little bit more clarity than a screening test because you're already coming in with a lump when you're there. there we want to try to know as much about it as possible. But either way, you can, go to an imaging center, tell them that you want to have a mammogram. They will contact your primary care doctor automatically. If they do find something, you will be mailed a letter to your home as well. So they are very particular to make sure that you get these results the right way. Your primary care physician then might choose to refer you either to a medical oncologist or to a surgical oncologist. Okay. Oncology generally being the field of cancer, there are doctors who operate and who do surgeries, which are called surgical oncologists. Myself, I treat patients with cancer with medicines. I'm a medical oncologist. And the third prong is a radiation oncologist, patients who treat with radiation. So your next step should then be, if it is something that is suspicious on your mammogram report for something that needs a biopsy or a piece of tissue to identify what that lump is, to see either a surgical oncologist or a medical oncologist who can direct you further.
So how do you make a definitive diagnosis?
A definitive diagnosis is made by a procedure called a biopsy. Depending upon where the lump is in your breast, there are a few different kind of biopsies that can be done. If your lump is very superficial, oftentimes when you see the surgeon, they may be able to put in a very thin needle after numbing the area, making sure you don't have any pain, and pulling out some cells right then and there and sending it out to the lab to examine. Optionally, you may be able to get something called a fine needle aspiration or a slightly bigger amount of tissue called a core biopsy. All of these procedures, in a sense, involve numbing up the skin of the breast tissue, making sure you're comfortable, positioning you in a way that lump is very clearly visible on the films while you're doing the biopsy, and then getting a small amount of those cells from the lump itself and sending them to a pathological laboratory to examine it under the microscope. A biopsy turnaround time is around 3 to 5 days. You want to make sure that your pathologist is able to take their time to make a correct determination of what they are seeing. You don't want them to give you a haphazard result. You want the results to be very accurate. And again, then follow up with your doctor.
Listening to Heartbeat, this is EBC Radio. I'm Dr. Dinesh Singhal. We've been talking to Dr. Seeta Trivedi. She's a medical oncologist with the Regional Cancer Care Associates. And our topic today was around breast cancer. Once again, the phone number in the studio is 732-297-9886. The first half of the program is kind of done. I hope you've learned something. Again, just as a reminder, this is a common problem, but if it's diagnosed early, it's fairly curative, as we'll get to in the second half of the program. So early diagnosis is important, and self-exam and mammography. But not every mammogram means that abnormal mammogram means that there's going to be cancer. We'll be back right after this commercial break, so stay tuned. And again, hopefully you enjoy the program. Welcome back, listeners. You're listening to EBC Radio. This is 1170 AM. Program is Heartbeat. This is an educational program about your health, which airs on EBC Radio every second and fourth Saturday of the month. I'm Dr. Dinesh Singhal. I'm an interventional cardiologist with offices in Somerset, Monroe, and East Brunswick. Today in the studio, we have Dr. Seeta Trivedi. She is a medical oncologist, and our topic today is around breast cancer. As I said in the first half, in case you missed that piece, there was a big news item based on an important study which was released in one of the society meetings and was in the New England Journal of Medicine, which suggested that they had now kind of figured out that some women who previously were getting chemotherapy and going through all the side effects of chemotherapy may not need chemotherapy for breast cancer. And that kind of led us to a discussion on this topic. And in the first half, we've kind of touched on the diagnosis and the incidence of breast cancer. And we will get into the treatment with Dr. Trivedi now. The phone number in the studio is 732-297-9886, 732-297-9886. If you have any question, comment, clarification, you want to share some experience, feel free to give us a call in the studio. So we have someone who you've made a tentative diagnosis, you did a biopsy, you found that they have cancer. I'm assuming at this point you try and determine the gravity of the situation. Is it something which is low risk? Is it something high risk? And I'm assuming that your decision algorithm is driven by that. So I guess the next question is, how do you kind of separate out the lower risk cancer from something which is a higher grade?
Right. So again, both the mammogram and clinical assessment of the patient helps us tremendously in this. Around our breast tissue, in our armpits, and for pretty much throughout the rest of our body, all of us have these tiny glands, which are like bunches of small grapes, called lymph nodes. Sometimes if you have a bad sore throat, you might have noticed some swollen glands in your neck, your tonsils. These are all lymph nodes or lymphatic tissue, which act like soldiers in our body, and they try to filter blood. They try to collect bad cells or cancer cells in this scenario, and prevent them from spreading to the rest of the body. So the lymph nodes which are associated with our breast circulation are in our armpits. When we do a mammogram, we are also able to assess if there are any lymph nodes that we see on the mammogram, and of course on clinical exam whether there are any that we feel. If we do not feel or see any lymph nodes, then the chances are very high that you have an early stage breast cancer that hopefully will be treated with a minimum amount of difficulty. If a cancer is diagnosed and you are seen by a surgeon, then the next step then at that point would be to do a surgery to take that lump or take that tumor out. I mean, nobody wants it in the body. And at the same time, when the surgeon is doing a surgery to remove that lump, they are also going to check to see if the lymph node that drains the breast has any cancer cells that have started escaping. If there are no cancer cells in the lymph node, that is broadly categorized as early stage breast cancer. If you do have cancer cells in the lymph node, then further testing may need to be done to make sure that the cancer cells have not spread beyond the lymph node also. There is a very specific numerical staging system that helps to, again, give numbers to the extent of the cancers, and this is an assessment that is made by your oncologist. But in a good percentage, around 70% of women who are diagnosed with early stage breast cancer, where their cancer cells have not got into lymph nodes, once your surgery is done, the next step is to try to figure out what your risk is that this cancer may come back sometime in your lifetime. And according to that risk, we determine what the next treatment is.
So is surgery advocated and done in most of the patients who are diagnosed?
Yes. Unless the cancer has spread beyond your breast, beyond your lymph nodes and into your organs, which is your liver or your lungs or your bones, which is approximately seen at around 5 to 10% of patients are diagnosed with stage 4 cancer the first time they're diagnosed. Your first step after being diagnosed with cancer on biopsy is to see a surgeon to try to have the lump taken out.
So now broadly, when it comes to management of cancers, there are 3 treatment modalities: surgery, chemotherapy, and radiation,
Correct.
right? So it sounds like majority of the people, unless it's spread, will need surgery.
Correct.
Right?
Yes.
So
surgery can be of two types.
Okay.
You could either opt for a smaller surgery, which is called a lumpectomy, meaning that you're taking the lump out, or you can opt for a procedure where the entire breast tissue is removed, which is termed a mastectomy. Either way, after you have surgery done, you are still going to need medical treatment. And this is oftentimes a confusing part for patients when they feel that, oh, we already did the surgery to take the lump out, or we already took the breast out. I don't need any further treatment. That is incorrect. You still need more treatment.
But going back to the surgery, how does one decide whether a lumpectomy is enough or a mastectomy is needed?
It's oftentimes either one of the two is possible. Okay. Most of the times the entire breast does not have to be taken out. And it is also important for women to know that taking out your entire breast versus just taking out the lump and then getting radiation treatment is exactly the same in terms of what the outcome is going to be. How long you're going to live, how well you do after your cancer does not matter if you just take the lump out or if you take the breast out. And that will be decided by your surgeon depending upon how big your breast is versus how big the tumor is. If you're going to wind up with having a very disfigured area in the breast because the lump is almost as big as your breast is, you probably want to go for the surgery called the mastectomy. Nowadays, there are lots of good plastic surgeons who are able to reconstruct the breast that has been operated on. Implants, flaps, plastic surgery is now state of the art. And so even after you have either one of these two surgeries, your breast can be reconstructed.
You're listening to EBC Radio. This is Heartbeat. Dr. Dinesh Singhal. We're talking to Dr. Seeta Trivedi. And our topic today is around breast cancer, and we'll get to the issue of who can avoid chemotherapy, because that was the big topic in the news. The phone number in the studio is 732-297-9886. Okay, so patients had surgery, and now there was a quandary whether someone needs chemo or not. So what goes into this decision-making of whether chemotherapy is needed? And then I guess we'll get into the choices of the drugs.
Correct. So if your cancer is an early stage cancer, meaning that, again, it is only in the breast and it has not got into those lymph nodes or lymph glands that I mentioned, or it has not spread anywhere else to the rest of your body, then there is then there are certain tests that are done on the cancer cells itself that help us to determine what the next step in treatment is. Because the breast tissue is part of the female reproductive system, the breasts respond to manipulations in the body by estrogen and progesterone hormones. A simple example is, as girls grow up and go through puberty, the breasts develop. In pregnancy, the breasts get larger. After menopause, the breasts start getting not exactly smaller, but less dense. And all of these are because of the levels of estrogen and progesterone in our body. It goes to say that when breast lumps or breast cancers form, they are also forming from the breast tissue itself. And so oftentimes the breast cancers also are responsive to the presence of these hormones in our body. So there are 3 tests that are checked very routinely on your breast cancer specimen, whether it is sensitive for estrogen markers, whether it has progesterone markers or progesterone receptors on it, and a third marker called HER2, which is also a cell signaling receptor, which can make the breast cancer more aggressive. If you have hormone receptor positive, which is estrogen receptor positive, progesterone receptor positive or negative, and the HER2 receptor is negative, okay, then the outcomes of your breast cancer may be different from somebody who does not have any of these markers, or somebody who has the HER2 marker, or somebody who has cancer in the lymph nodes. So the best scenario would be an estrogen receptor positive and HER2 negative early stage breast cancer.
So, just if I were to reword it, there are internal characteristics which make tissue more responsive or get influenced by circulating hormones. And what you're trying to determine is what is the probability that this tumor which was there is going to start acting up because of these external influences. And that goes into the decision-making process of whether some additional treatment is needed to prevent that outside influence to kind of rake this whole thing up all over again.
Good.
What percentage of folks wind up needing or requiring chemotherapy?
So I think around 10 to 15 years ago, I would say that almost 80 to 85% of patients used to get chemotherapy. Recently, the literature that you mentioned that came out was results of a trial that we called the Taylor X trial that looked at recurrence scores. So now, cancer cells are different because of the genetic mutations in them. There is a test that we call the Oncotype DX recurrence score that looks at 21 different genes in the cancer cells itself. There are some of these genes that work to the patient's favor. Some of the genes are more aggressive and bad type of genes. And depending upon what score your cancer cells have, which is something a pathologist finds out, we can divide that particular cancer into a low risk score or an in-between risk score or a high risk score. Patients who have a low risk score with a score less than 11 almost certainly do not need any chemotherapy, which means that after you've had your surgery, you can get your radiation if it is needed and recommended, and then you could treat your cancer by a simple once-a-day pill for a duration of 5 years. And there are excellent, more than 65% chances that this cancer will not come back. And the 5-year survival rate is nearly 99%. So out of 100 women with this kind of cancer, 99% will be alive without anything except surgery and a simple pill and perhaps radiation at the end of 5 years. And that is very, very significant because the word chemotherapy is scary. The word chemotherapy gives different people, different scenarios. They may have seen a loved one or a family member who may have been through this. Women are always concerned about hair loss, change in appearance, change in energy levels, being able to take care of their family members and children and, parents and so on and so forth. And right off the bat, if you have a hormone receptor positive HER2 negative cancer that is not in your lymph node and you have a low recurrence score, then you are just getting a pill a day. The Taylor X trial published a second part of the report just a few days ago, which looked at women who were in that in-between risk.
Well, before we get into that, let's just talk about the high-risk people first.
Yes.
Yeah.
So the high-risk people, unfortunately, need chemotherapy.
And that's a score of what?
That is a score above 34 traditionally, but it is also looked at a score about 25 is also considered high-risk in many papers. These are patients who have certain aggressive genetic mutations in their genes, whose risk of cancer spreading outside the breast tissue is very high, and we want to try to make sure that the chemotherapy is able to kill off any cancer cells that might have escaped, might have made their way into the bloodstream, and might already be starting to grow and develop at other places in organs, in the lungs, the bones, the liver, and might risk making that cancer a stage 4 or incurable tumor. So these women do need chemotherapy. And again, choices of chemotherapy that are offered vary by age, vary by certain other tumor characteristics, vary by the patient's general health itself. But in general, the certain different drugs that we use are cyclophosphamide, adriamycin, Taxotere, docetaxel, that is, and there's many different regimens, and it is an individualized choice. It is not a one-size-fits-all.
So prior to this study, you had situations where the score was below 11 based on this genetic test, and you kind of left these women alone, gave them a pill. If the score was high,
we gave them
20,
chemotherapy.
You gave them chemotherapy. And so let's just talk about what you did before the study. What happened to these people who kind of fell in between 11 and 20? How did you manage them before this data came out?
So unfortunately, we did not know the correct way to manage them. We tried to manage them by, again, taking each case by case and trying to understand for patients who had a slightly closer to this, 11 number score, slightly lower score, we would try to manage them by hormonal suppression alone. For women who had a score, beyond 20, 25, we would offer them chemotherapy and try to tell them that they still had a risk of the cancer spreading, the cancer coming back and being more aggressive. What we do know now in the paper that came out was that women who have an intermediate risk score, which is a score less than 25, also have an excellent chance at the end of 5 years with hormonal suppression alone and not getting any chemotherapy of living a very healthy and productive life at the end of 5 years. And the survival rates were again very close to 97%. This means that 2/3 of women who are diagnosed with breast cancer that has not spread to their lymph nodes are not going to need any chemotherapy. Okay, again, remember, the reason I go back and keep stressing the part about hormone receptor positive and HER2 new negative women are the women that we are talking about. Women who are HER2 new positive or do have cancer in their lymph nodes are a separate category, and they are treated with chemotherapy. But a majority of patients which are hormone receptor positive and are HER2 new negative now do not need chemotherapy.
Well, that's the new data. So let me just again clarify. So there was this intermediate group where you weren't sure what was being done, what was to be done, and a good number of those women wound up getting chemotherapy with all the side effects which came from it. So how did they conduct this particular big study to help these women in that intermediate score, and what did they find?
Right. So this was a study that was done internationally, which registered over 10,000 women, and it was called the Taylor X trial. The trial was started around 10 years ago, and they enrolled women onto this trial who had hormone receptor positive, HER2 new negative, breast cancer that had not involved their lymph nodes. And then all of the patients' tumor lumps had this specific test done on them, which is called an Oncotype DX score that I mentioned. And all of them were given a score, and depending upon what their score came as, 1 to 11, 11 to 25, and then greater than 25, were placed into 3 categories. And the intermediate ones, which were the 12 to 25 score patients, half of them were treated with chemotherapy and half of them were treated just with hormonal suppression. The chemotherapy patients also then went on to get hormonal suppression as well. And these two groups of women were followed clinically over this period of 9 years to try to see which ones had their cancers coming back and when did the cancers come back. And the women who did not get chemotherapy did as well as the women who did get chemotherapy, which means that if I gave someone chemotherapy, it did not give me any additional benefit except giving me side effects, because even if I did not get chemo, I still did as good. So we now know that chemotherapy can be safely avoided. Hair loss, fatigue, nausea, vomiting, skin changes, nail changes, diarrhea, changes in your taste. These are all side effects that do come with chemo, and we can avoid them.
So that's great. This was a great summary of the issues related to breast cancer. And Dr. Trivedi, I appreciate now, before we just wind up, just tell us, or tell the listeners, if somebody does get diagnosed with breast cancer, where things stand just broadly, in terms of the hope they should have in terms of getting treated and possibly cured. Just where things stand today. We have about a minute.
Right. So there is excellent care in the U.S., in the Northeast. Dr. Singhal, I think St. Peter's has an excellent breast cancer center that treats and takes care of patients who have breast cancer. There are new therapies being diagnosed every day. Even for women who have stage 4 breast cancer, average or median survival time is 4.5 to 5 years, which is longer than most cancers. And so you should seek treatment. Go ask for help, go see a medical oncologist, and then assess what your options are.
I think the other big message is there is no substitute to being proactive in diagnosing and getting these diagnosed early. So the self-exam and a regular mammography based on guidelines is huge, because this is a curable problem. Unfortunately, it'll occur to some people.
Correct. And for specifically our Southeast Asian population of patients who are hesitant, there are taboos about, breast health and getting their mammograms, please go out and get your mammograms. Everyone is doing them. It just takes an hour of your time. Encourage your moms, your sisters, your daughters to get your mammograms too.
And again, just a plug-in for a good lifestyle. Obesity is also related.
Correct.
So exercise, eat healthy, and